Hey, what's up guys? My name is David Hinden. I am a trauma surgeon, and today we're going to be reacting to famous movie scenes. Let's go. It's been a little while since I've seen this, and I was a med student last time I saw this, so this is going to be interesting.
Bond's been poisoned. He's going into cardiac arrest.
Stay calm.
And don't interrupt, because you'll be dead within 2 minutes unless you do exactly what I tell you.
Okay, so you can definitely have cardiac arrest from all sorts of different poison. That's true. But the whole business of being dead within 2 minutes if you don't follow someone's instructions, not super reliable to be able to say that to someone. And also, he's awake, he's interacting, he's not in cardiac arrest. If your heart is not beating, you don't maintain consciousness for more than a second or two. Let's keep going.
I'm all ears.
Remove the defibrillator from the pouch. Do not.
What it is yet? Still scanning.
Attach the leads to
All right, that's a pretty fancy defibrillator. Again, he's not in cardiac arrest, although you could be in different cardiac dysrhythmias that require you to be shocked out of it. I guess be somewhat awake enough to put pads on yourself, but really, we're getting into territory that's not likely, if you couldn't tell.
chest.
That'll work. Bond.
Don't push the red button.
Yeah, do you hear me? Don't push it yet.
His heart's gonna stop.
All right, so what they're talking about with the charging is something that actually happens at the bedside when we're about to shock a patient. So the device builds up a certain amount of charge, and then when you hit the button, it discharges and shocks your heart. There's a little bit more nuance into how this happens, but what they're looking at is correct. You have to wait for the machine to sort of develop enough voltage to be able to shock yourself, but it wouldn't take this long. And definitely, if you had something this fancy, it would probably be able to charge a little faster.
Push the red button now, Bond.
This is a great scene. I don't know what else to say. Usually leads don't detach quite that easily, but hey, this is Hollywood. It's a good scene. I'm feeling the tension here. That response to a shock is accurate. Being shocked is incredibly uncomfortable for patients who've gone through it. And so when we're shocking patients, if they're awake and they're in a dysrhythmia that isn't giving them enough blood flow and they need to be shocked out of it, we give them a sedating medication so that they're not fully aware and fully conscious during the shock. If someone is totally asleep or totally in cardiac arrest, it's less of an issue because they're less aware of what's going on. It's a great movie.
You okay?
Hey.
All right, that was awesome. Alan Kumar, Go to White Castle, 2004. Here goes.
If we get caught, you are taking the blame. This is not my idea.
We're not gonna get caught, okay? We're gonna go get baked and then go.
So I'm just going to say I don't know what roles these guys are playing in the hospital environment. Usually you can tell a lot about someone just at a glance based on how they're wearing their scrubs. So the untucked scrub top look that we see here, not super common among nurses, not super common among residents or doctors. Usually the scrub top's tucked in. Also, the long sleeve shirt that he has on under his scrub top, not super common. I don't see that a lot. Usually it would be someone who's wearing scrubs that's not really having much interaction with patients, and certainly not someone who is scrubbing into the operating room because you can't have long sleeves and make yourself sterile.
Hey, we're gonna go get baked and then go eat just like we planned. Now just calm down. We gotta find the pharmacy.
Dr.
Think
Patel!
of something.
Thank God I found you. We have an emergency. Nurses, I need these two doctors strapped, gloved, and ready for the OR stat.
What the hell is going on?
He probably thinks I'm my brother, okay? Just don't worry about it. Leave the talking to me.
The whole business of scrubbing in with someone just throwing something on you, that would never happen because you have to wash your hands and do the whole thing where you're sterile and then you get into the gown and everything that way. So that's one thing that wouldn't fly. Also the long sleeve stuff that we just talked about.
It's a godforsaken bloodbath. The patient was brought in by EMS 5 minutes ago. As you can see, we have 3 horrific gunshot wounds. It's a good thing I found you two. All the other surgeons are working on other patients.
No. There's been a mistake, you see.
Excuse me. What Dr. Lee is trying to say is that we need to sedate the patient or he could go into cardiac arrest.
Not really a thing. The whole sedating a patient to prevent them from going into cardiac arrest. Patients can go into arrest after unfortunately being shot or any other source of blood loss. because there comes a time where you're losing so much volume that your body arrests. It can't keep going. But it would never be a situation where you want to give them sedation. That could even drop their blood pressure even more.
Hang on a second, nurse. What we should probably use is marijuana. That'll sufficiently sedate the patient for surgery.
I love how the patient's looking at him. There is such thing as medical marijuana. That's not how it's used.
Marijuana? But why? We don't have time for questions. We need marijuana now, as much of it as possible. Like a big bag of it.
But doctor, we don't have marijuana in this hospital.
This guy's gonna die!
Doctor, you've got to do something or we're going to lose him!
I'm gonna have to do this the old-fashioned way. Start the nitrous, please. Give me 2 large bore IVs and start a Ringer's lactate.
Some of these words that they're using are real. We don't start the nitrous in the hospital for patients that need to be sedated for surgery. And that's something that we sometimes see used at the dentist's office, and it can be used in an awake patient who's breathing on their own. Lactated Ringers, you may have heard him mention, that's a type of IV fluid that we give patients for resuscitation, sort of replacing their volume. But nowadays in trauma, when a patient's losing significant amounts of blood volume, we don't give them IV fluids, we just give them blood back.
Push, doctor. Roll deep. Hold this.
There's this thing in Hollywood where when someone gets shot, like The Cure is pulling the bullet out. We don't always take the bullet out. Often after doing the definitive surgery to fix the problem, we leave the bullet behind unless it's sort of in our operative field. Bullets will eventually sort of work their way up to the skin surface, and then they can even be taken out in the office. Rarely are they the problem that's sort of causing someone to be sick. Usually it's what's happened in its pathway and the injuries it's left behind that have to be fixed.
More gauze, please.
Doctor, the patient is desatting.
Dude, he's desatting. He's desatting!
Patient has collapsed lung. I need a 14 gauge angiocath stat.
What just happened, the patient desatting, collapsed lung, that is something that can happen if someone has what we call penetrating trauma. So either a bullet or a knife has entered someone's chest. The whole contraption he's using here that's hooked up to the needle is not what we would actually use. It would just be a plain needle on its own, and you can actually kind of hear the air hiss out, and then we replace that with a chest tube.
That was genius.
Thank you. Great job! You guys did it. No, it's you.
Sexy.
What'd you say? Nothing.
That was great. Anaconda, 1997. I actually haven't seen this one.
Dad, be careful. What is this? What is this? Careful. Careful.
Got something for his head.
Okay.
right.
He's not breathing.
Not breathing.
He's not breathing. Wait.
Something for his head.
Here.
There's something in the mouth.
So this is important. Whenever we have a patient who either out there in the population sort of living life in the world or in the hospital, whenever we find that they're not breathing, one of the first things we do is make sure that the airway is clear, make sure that there's not obvious food debris that can be swept out of the mouth. Second, we feel for a pulse.
Oh, God. Oh, damn, what's that?
I'm not a bug guy. That's disgusting to me.
Deadly. Poisonous.
Well, he's still not breathing. What are we gonna do?
All right, so I'm just going to pause this right here. You see this guy reaching for the knife. I have a feeling this is going to be the infamous Hollywood cricothyrotomy with a Bic pen or some sort of pen. Let's just see if that's right.
Oh, God, how
Yep,
does
it's got the
happen?
pen.
Alcohol.
Is he going to do it?
I got whiskey in my flask.
A couple things are problematic with this. They haven't checked for a pulse, so it's important to establish an airway, and that comes before restarting someone's heart. But it's surprising that nobody in this conversation has felt to check his pulse, because he looks like he hasn't been breathing for a while. Second of all, we wouldn't really be able to sterilize it using whiskey. That's just not a thing.
Quickly.
What's that for? What are you...
A couple things here. One, the location may be correct, may not be. It looks like the sort of dummy neck that they're using for that incision doesn't actually have really clear anatomical landmarks. So where a cricothyrotomy is performed, and I have a video, I'll have it linked up here, but a video that I've done before explaining this. It's in the cricothyroid membrane. So if you feel your Adam's apple, right? Feel your Adam's apple, and then you slide your finger down, and you feel that next big lump past it, That's the cricoid cartilage. Now, if you feel the divot between the two, this is the cricothyroid membrane right here. And when you're doing a cric, one of these emergency airways, you want to make an incision on the membrane. This guy just kind of glancing and jabbing the knife in, not super realistic, because usually we take at least a minute or two to sort of feel it with our finger and make sure that we're in the right spot. Second of all, it wouldn't just be a single jab. Usually we make an incision. When I've done these before, I usually do a vertical incision so that you can extend it if you need to. And you're going to make a big enough incision so that you can see where you are. All right. Yes, he's doing the correct thing in terms of putting a tube in here. The reality is the ability to just make a jab with a knife and then slide a tube in and automatically be in the right spot, that'd be a very, very unlikely chance. Assuming that all of that worked, the next question you have is, can someone breathe through this? And if you imagine yourself being wide awake and being given a straw and having to do all of your breathing through that straw, you can imagine you might get pretty tired. It's hard to move a whole lot of air through a straw, and if that's the only way you can breathe, that would be exhausting. So that's something that we don't really see being a challenge, but it is.
That's it. It's gonna be all right.
I just love all the confidence in the world. He's gonna be all right. So again, it's unlikely that this patient would be able to breathe without struggling through that tiny straw. If we're in a healthcare environment, as soon as we do a cricothyrotomy, we're immediately hooking that tube up to a ventilator. If we don't have a ventilator available, someone is holding what's called a bag. It's like an inflatable balloon that we do some of the breathing with so that it does some of the work for them. So that's not super realistic for me here. The other thing is he's like totally asleep. He's like unconscious, but somehow we're supposed to assume that he's able to breathe just as much as he normally would. Also a little iffy. If you want to see more reaction videos, click here. And if you want to see some of the other videos on my channel, click here. I'll see you soon.